Hi, I'm Allon Kahn. I'm a gastroenterologist and esophageal specialist at the Mayo Clinic in Scottsdale, Arizona. I want to thank the editorial staff of Gastrointestinal Endoscopy and the ASGE for the opportunity to present our research in this author interview. So first, why did we conduct this study? Well, the use of endoscopic eradication therapy for early-stage esophageal adenocarcinoma has gained widespread acceptance and is now guideline recommended and commonplace. This is based on several studies showing early outcomes of endoscopic therapy are at least comparable to surgical esophagectomy with an improved safety profile. We have this concept of 5-year survival in clinical oncology that's often cited and reflects a very important clinical endpoint. However, having an understanding of treatment outcomes past 5 years is really critical for us for two purposes. First, it helps us to advise patients about risk when making decisions about surgical versus endoscopic therapy. Second, it helps to guide our understanding about tailoring a surveillance paradigm after successful treatment. With the proliferation of endoscopic eradication therapy, we are now encountering many patients who have lived long past 5 years and require this information to guide our practices. Existing studies of treatment outcomes for early esophageal adenocarcinoma treated endoscopically are limited by a fairly short duration of follow-up. So we conducted a study designed specifically to answer this question. We combined prospectively collected patient databases from several tertiary care referral centers. Those include the 3 Mayo Clinic campuses and University of Pennsylvania. And we included all patients that were treated endoscopically for T1 esophageal adenocarcinoma. In order to include a patient, they were required to have achieved remission of cancer and dysplasia using endoscopic methods. We specifically excluded any patient with a history of nodal or distant metastatic disease as defined by a combination of EUS and cross-sectional imaging. We also excluded any patient who underwent a surgical esophagectomy within 100 days of the index endoscopic resection in order to only include patients whose primary treatment was endoscopic, in other words, with curative intent. The primary outcome we were looking at was the rate of late recurrence, defined as being over 5 years after cancer remission. We also examined secondary outcomes, including cancer recurrence, clinical outcome and management of recurrence, and predictors of recurrence, both histologic and clinical. We calculated recurrence incidence by dividing the incident cases by the number of patient years of follow-up, and then calculated time to recurrence. We also analyzed predictors of recurrence by Kaplan-Meier method using Cox proportional hazard models. Because of a limited number of neoplastic recurrences, these were only univariate association tests. We identified a total of 205 patients in the initial database query. We filtered these through our exclusion criteria, resulting in a final data set of 84 patients. These patients had a median follow-up of 9 years. 89% were staged as T1A, the rest being T1B. Most patients had well or moderately differentiated adenocarcinoma. Only 5% showed LVI, or lymphovascular invasion, on resection. 94% of these patients achieved complete eradication of intestinal metaplasia with a combination of endoscopic techniques, including ablation. 14% experienced strictures during treatment, and these were managed successfully with dilation. We saw recurrence in a total of 16 patients at a median of 3.8 years. That comprises 19% of the total patient population. The recurrence histology was 7 low-grade dysplasias, 1 high-grade, and 8 esophageal adenocarcinomas. These recurrences correspond to an incidence of 2 per 100 years of follow-up, 100 person years of follow-up. For our primary outcome, of these 16 recurrences, 7 of them occurred late. That's 44%. 3 were dysplastic and 4 were cancerous. Most recurrences were evident as nodularity in the distal esophagus. 2 patients did have esophagectomy after an unsuccessful attempt at endoscopic resection of their recurrent cancer. Both of these patients are alive as of 2021. Recurrence was more advanced than the initial cancer in 4 patients. 2 patients actually experienced lymph node metastasis as a recurrence with no cancer within the actual esophagus. 3 patients died from recurrent adenocarcinoma. This corresponds to an incidence of 0.4 per 100 years of follow-up, 100 person years of follow-up. The median time from cancer remission to recurrence in this group was 5.2 years. So 2 of them actually recurred and died from recurrence after over 5 years of follow-up. The median time from the recurrence to death was 3.6 years. In our predictive model, complete eradication of intestinal metaplasia was significantly associated with reduced recurrence. When we restricted the analysis to just high-grade dysplasia and cancer recurrence, this was no longer the case, though. So what do I want you to take away from this study? Well, these data represent our best attempt to understand the long-term outcomes of this very specific but rapidly expanding patient population. This is now the largest study with the longest duration of follow-up published to date. We learned several important things from this study. First, in many ways, it would be ideal to see that neoplastic recurrence is only an early phenomenon and gradually fades with each successive normal endoscopic surveillance. Unfortunately, our data paint a different picture. In this study, between remission and recurrence, the number of biopsy-negative surveillance endoscopies was 6, and that is the median. Half of recurrence occurred late and can even manifest as distant metastatic disease. So we must remain vigilant for recurrence, as additional endoscopic and even surgical therapy may be needed to achieve optimal outcomes. Second, cancer recurrence after successful endoscopic therapy can lead to death at a higher rate than previously recognized. While having a 4% cancer mortality over 9 years after successful endoscopic eradication is quite low, it reflects a reality that we must share with our patients when they make decisions regarding therapy. Third, our analysis suggests that achievement of complete eradication of intestinal metaplasia reduces the likelihood of recurrence. This is in agreement with prior studies in the Barrett's esophagus treatment literature that show that persistent intestinal metaplasia is associated with a 4-fold higher risk of neoplastic recurrence. Therefore, eradication of metaplasia remains an important goal after initial cancer remission. Patients should be counseled that ongoing endoscopic therapy, such as ablation, may be needed to achieve optimal outcomes. These data overall emphasize the importance of diligence in surveillance of this very complex patient population, and to continue surveillance until it is medically inappropriate to continue doing so. The decision to discontinue or lengthen surveillance in this group should take into account these data and should be carefully individualized to the patient's values and health status. Thank you to the listeners. Thank you to the ASGE and to GIE for this opportunity, and thank you for taking time to learn more about our study. Thank you very much.